So
Mhm.
uh, there, uh, we know there's been tremendous advances in heart failure with the four-pillar strategy, ACEs and ARBs, or sacubitril valsartan, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. But despite all that, there's still a significant number of people that have progressive heart failure and go on to die. A lot of them have concomitant renal disease or diabetes. And it's increasingly recognized that inflammation plays a critical role. We know very well at the moment what we should be doing in heart failure, reduced ejection fraction. We're going to have further information at the ESC on HFpEF when we hear the results of fine arts. We're still blinded, but we hope that the nonsteroidal MRA finerenone will be positive. We don't know yet. Uh, but despite all that, we know that there still is this inflammation, and that despite what we do, many people, especially the elderly and with people with renal disease and diabetes, go on to have progressive failure and hospitalization. Now, Dr. David Humes at the University of Michigan, who's a nephrologist, has developed a technique where he uses sort of a dialysis-like uh, system where he attaches a catheter and passes the blood through a low calcium concentration and then returns the blood. During this time when the blood passes through this low calcium environment, it deactivates all of the activated neutrophils and changes the macrophages from pro-inflammatory to anti-inflammatory. And uh, he has shown that in sepsis and bad renal disease, they have significantly improved outcomes. There is some animal data that has been shown that this same technique can improve ventricular ejection fraction, and it hasn't really been applied systematically to heart failure. So what we proposed in that article is to use this technique, especially in people who have uh, bad heart failure, recurrent heart failure with renal disease, uh, to see whether we could turn off the inflammation and uh, improve outcomes. I think from everything we know from the previous studies in sepsis and in renal disease, this should be very successful. So it requires a catheter and to pass the blood through this filter and return it. And so these would be people likely who would be in the intensive care unit, already easy to put in a catheter, or uh, one of the groups we've talked about are people who are bad heart failure who would receive an LVAD, but because of bad renal function, they are contraindicated. But it's much more than that. I think just people with recurrent heart failure who've had several admissions and who are not responding very well. Uh, just a few days of this turns off, as I say, all of the activated neutrophils and should have a long-lasting effect. Now we have to prove this, but I think it's a different approach. Obviously, people are using other approaches for inflammation, IL-6 antibodies, etc., uh, colchicine, but those are all very good and would probably be used in conjunction of this long term, but acutely, this would be a very quick way of doing it because you, as I say, you deactivate all of the activated neutrophils. So it obviously uh, has to be proven, but it has already been proven in sepsis and renal disease. So there's no reason we think that it wouldn't be successful in the right patients in heart failure. So I think it is a very promising approach for the future, but takes a lot of work.
Envisage like some difficulties in for patient to tolerate the procedure from the hemodynamic perspective, because sometimes
No, it just passing the blood through. It doesn't affect blood pressure, or it's not hemodynamically challenging at all. So the blood
absolutely.
is returned uh, to this in the circuit back as it passes through this low calcium filter.
Okay. So the next steps then would be to try and apply it and test it.
Yes, well, Dr. Humes has a grant from the NIH where he's looking at people who are with bad heart failure, as I said, coming for an LVAD, and we're uh, trying to uh, do other studies in people with acute heart failure. But it's early days, but I think it's a very promising approach. But until we have more data, I think in heart failure at least, I think we have to wait a little bit. But we're very excited about the future.
Absolutely, and we are too. It sounds absolutely a, probably a new avenue
Yeah.
in the treatment of acute heart failure. And well, as you just mentioned about this very important collaboration with nephrologists. So, I mean, we know how much the collaboration, scientific collaboration, plays really much a crucial role in academic research. Would you be kind enough to discuss with us some of the collaboration you've been having, you have at the moment, and how they really have influenced your work and your approach to research?
Well, had several collaborations over the years, but one of the most persistent is with Dr. Fayez Zenad and his group in Nancy, France, and Patrick Rossignol from the same group and other members of that group. From the early days, I first started working on aldosterone and mineralocorticoid receptor antagonists somewhere in the 1990s, and we did the RALS trial, then Ephesus, Emphasis, then TopCat. And Dr. Zanad has been involved right from the beginning, and he has led some of the trials. He led the Emphasis trial. I led the RALS and Ephesus and TopCat, but we've worked together over the years, and this has been a very important collaboration with him and his colleagues, as I said, Dr. Rosenall and Zanad. Other collaborations I've had in the past, when we were first developing eplerenone, uh, I was working very closely with Dr. Gordon Williams at the Brigham Hospital, and he is a world expert on aldosterone and was very, very helpful in our understanding. And still working with him, we just recently published a, a short article in Circulation talking about the potential differences between a mineralocorticoid receptor antagonist and an aldosterone synthase inhibitor. There's a lot of interest in the aldosterone synthase inhibitors, but we pointed out that they are likely to be very good, but there may be circumstances where a mineralocorticoid receptor antagonist may have an advantage, because once the MR is upregulated, it can be stimulated not just by aldosterone, but by RAC1 and other substances. So it may not be sufficient that just to turn off aldosterone, but there's a lot of work that has to be done, but we pointed out that. So that's another collaboration. And in renal disease, I've been working with Dr. George Bacris at the University of Chicago, who is a well-known nephrologist, and uh, we worked together on the finerenone studies, Fidelio and Figaro. Dr. Bacris led the Fidelio study in people with severe renal disease and diabetes, and I led the study in more mild renal disease and diabetes, Figaro, with finerenone. And both of those trials were very positive and showed a reduction in heart failure in people with renal disease and diabetes, as well as reduction in progression of renal disease. And now finerenone has been approved by the FDA for use in chronic renal disease with diabetes. And it's being studied, as I mentioned at the beginning, in heart failure in preserved ejection fraction in the fine arts trial, which will have the results somewhere in the ESC. So Dr. Bacris and I have collaborated and pointing out the importance of aldosterone in people with resistant hypertension, although spironolactone has a class 1 indication in resistant hypertension. Unfortunately, it's used pretty infrequently because many of the people have concomitant renal disease, so people are frightened, but we pointed out the importance of somehow combating the effects of aldosterone and MR activation in several articles, and one about a year ago in the European Heart Journal, and we're writing other articles. So I think I've had a number of collaborations that are very important. And I think these days where everything gets more complicated and we cross disciplines, these collaborations are extremely important.
Absolutely, and yeah, and we are very well aware of as a European also. I'm European, so I'm quite involved in the ESC as well, and now on I'm working in the US, and I could see all these like absolutely very good interaction between let's say those two type of Western world, let's say,
Yeah.
and
I
how
have to
often.
mention one other collaboration I've had. Dr. Anand Vadia at the Brigham in Boston and Harvard has done a lot of the work recently showing the importance of aldosterone. We know that primary aldosteronism is present in maybe 10 to 20% of resistant hypertension, and it's far maybe more important than we thought. But his work has shown that there is low renin dysregulated aldosterone that occurs in about 70% of people with resistant hypertension. So they may have normal serum levels of aldosterone, but it can be stimulated by ACTH or other substances. And uh, he was, and his group was able to show that even normotensive people, some of them have this dysregulated aldosterone. And when you have this, it leads to further disease and progression. And it also activates immune system. You have T cell activation, macrophage. So it turns out that aldosterone and the MR are far more important than we ever thought. They're class 1 indications in HFrEF and in resistant hypertension, but hopefully we'll have some data in HFpEF. But I think more importantly, we think that given this new data, uh, these strategies will be even more important in preventing heart failure in people with hypertension, early stage hypertension, because if there is this high incidence of dysregulated aldosterone, low renin dysregulated aldosterone, and it's not combated, lowering blood pressure is clearly very important, but we believe it's essential, but not sufficient. You have to do more to prevent the occurrence of heart failure. So you need to lower the blood pressure, but you also need to combat the effects of aldosterone. So this is a whole new area, and we obviously need the clinical trials to look at safety and cost effectiveness. Hypertension requires drugs that are relatively inexpensive. And people are going to take them for a long time. And so we have a lot of new drugs coming, but they'll be relatively expensive. The aldosterone synthase inhibitors look very promising, not yet approved. We need to know more. And we have the new non-steroidal MRAs. So lots of things coming, but we think the opportunity, the greatest opportunity will be in heart failure, preventing heart in hypertension, preventing heart failure, and preventing renal disease. rather than treating it once you get it. Because once you have it, there's fibrosis and irreversible changes. So one would like to be there before you get those irreversible changes.
Exactly. Well, but for sure, these are the mineral corticoids, and all these new drugs are probably just a fraction of the full of the activities and the research effort you've been proposing during the
So I
past
would say the
years.
other thing we've been working with is
Mm-hmm.
there's a lot of interest, obviously, in the SGLT2 inhibitors, but we've been working with the SGLT1/2 inhibitor, sotagliflozin, and I was co-PI of the Soloist trial, and we published those results, and the Soloist trial with Dr. Bott and the SCORE trial. Those were very positive, and sotagliflozin is now approved. But what's very interesting to us is when you look at the SCORE trial, which was a trial in 10,000 patients with renal disease and diabetes, that sotagliflozin, the SGLT1/2 inhibitor, significantly reduced stroke and myocardial infarction by about 30%. When you look at the meta-analysis of the SGLT2 trials, agents that are very good, such as dapagliflozin, empagliflozin, they have been very effective, but you can't really find a lot of evidence that they're very effective in preventing stroke and MI. And we think this is due to the SGLT1 component. And one of my colleagues here, Dr. Michael Holenstadt, at the University of Michigan in pharmacology, has just presented an abstract at the ACC meetings showing that the platelet expresses SGLT1 and SGLT2, and that sotagliflozin has a very profound effect on blocking thrombosis. Now, more studies are underway, but we think that people with renal disease who have a high risk of stroke and myocardial infarction, that the added protection you get from SGLT1 inhibition may play a very important role. So lots of excitement about the SGLT2s, but I think the SGLT1/2 may have even more benefit in people who are at high risk of thromboembolic events.
That's fascinating, and also really would open a totally new avenue also in this. But ask you, out of all the research contribution that you've been given during all those years, of course, those you just mentioned are very new, very upcoming. But if you were to look back in all your very, very pioneeristic career, would you point at something that you think has really left the most profound impact on the field?
Well, I think the work we've done on aldosterone and MRAs, the RALS trial. So when we started in the early 1990s, spironolactone was used in hypertension as a diuretic, and it was very effective. It was used at doses of 100, 200 milligrams a day. And when we did the RALS trial, we first did a very careful dose finding trial, and we decided on a dose of 25 milligrams a day, where you could go up to 50 or down to 12 and a half. But I think the RALS trial, uh, which was highly positive, really changed the appreciation of the importance of aldosterone, and it's led to many other things. And I've said it's obviously a class 1 indication in HFrEF. We hope we'll see something in HFpEF, but more importantly, as I said, the future is prevention. So I think the RALS trial, which we did in the 90s, paved the way for all these future advances in understanding.
That's great. What is your, kind of advice, or what is your, counseling would you do to young scholars at the moment that they are approaching such a very, very complex research environment, especially in cardiovascular medicine? And we know how complex can be, especially translational medicine, trying to translate research from the bench to the bedside, and especially in cardiovascular research. What would you advise to young scholars in order to help them to navigate all those complexities?
Well, it's hard to give, definite advice, but I think for at least for young clinical investigators, people have asked, how do I get involved in clinical trials? Well, I think the best advice is to be in a place where they're doing clinical trials. And as a young investigator, there are sub-studies and other things you can get involved. And, these trials are often very large. They cost a tremendous amount of money. And so uh, a young person, it's just hard to uh, start leading a 10,000 patient trial that costs $100 million. So you have to start somewhere. But if you're in a place that is doing these clinical trials and you involved in some of the sub studies and some of the papers, that is an entry, and gradually you can assume the leadership of these trials, especially if you're doing translational research and have laboratory as well as clinical uh, access. But there's no single answer. And in this new world of artificial intelligence uh, and changing healthcare delivery, it's hard to predict exactly what's going to happen. But I think that's still pretty good advice, is to be in a place where there's a lot of good things happening.
Well, I'm very glad you briefly touched on the artificial intelligence, which is probably one of the most interesting emerging trends. Let's say, if you were to point at one of those trends or areas of research, looking at ahead, looking in the future with a glimpse in the future, what would you really think might have the most significant impact in the future?
Well, obviously, everyone is excited about artificial intelligence and what it's going to do to uh, diagnosis and manpower needs in cardiology. Will we be replaced? A lot of us, maybe. I don't know. I am 92, so my vision forward is a little more limited than maybe yours, but uh, I still think there's a very exciting future, and it's you know it's hard to tell exactly how all these things go, but healthcare delivery is certainly going to change. The costs are overwhelming, and we know that in the United States, despite all the money we spend, when you look at the parameters and compare our healthcare system and outcomes to other parts of the world, despite what we spend, we don't seem to be getting value for our money. So I think there needs to be a lot of changes, and hopefully artificial intelligence will be one of the ways, and paramedical people empowered, new devices. There's obviously a tremendous new approach in wearable devices, implanted devices. So one should be able to monitor many different functions, and the patient will be involved, as well as you can monitor thousands of patients having their data centrally. And it won't be just one parameter, it'll be multiple parameters. Some of these devices I've seen are put on by tattoos, others are implantable, others are wearable. So it's a very exciting new world, and we're just going to have to learn to see how to apply all this information.